TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree, Chappell, your host. Now, over the years here on TopMedTalk, we've been highlighting perioperative patient safety and exploring opportunities that we have as perioperative clinicians to improve the care that is being delivered before, during, and after surgery, especially within the hospitals and the floors and in the wards. Now, back with us today is a previous guest and friend here on TopMedTalk to discuss her work in this area of post-operative ward monitoring, Dr. Sadia Khan. Now, she's a consultant cardiologist at the West Middlesex University Hospital, which is part of the Chelsea and Westminster Hospital NHS Foundation Trust. Sadia, welcome back to the show.
Thank you so much, Desiree, and it's a real pleasure and honor to be back.
Yes. Well, we were just reminiscing about the last time. I think it's been almost 2 years now.
It has indeed been about 2 years, but it feels like it was only yesterday.
It does. It does. Well, Sadia, for our listeners, why don't you tell us a little bit more about yourself? Now, traditionally here on TopMedTalk, we talk to a lot of people from and clinicians from the anesthesia space, surgeons and things like that. But you're a bit of a non-traditional role for us here at TopMedTalk. So tell us more about yourself.
Well, I might be a bit of a non-traditionalist, but I've always felt more than welcome. So I'm a physician, obviously, by background, and a cardiologist. And since I started my consultant career, I've been really interested in remote monitoring technologies. And one of the things that we've increasingly recognized is that ability for technology to bridge distance and bridge specialties. So I originally started out doing a lot of remote monitoring work in the community, but my attention over recent years, particularly during COVID, shifted to what happens on the ward areas. And from there, it was a small step to looking at post-operative and surgical care and that patient safety challenge.
So we've had lots of conversations in the last several months, last year, really talking about, we want to provide safe care. We also want to improve care. Let's talk about just for a moment some of the concerns that you feel that we have in the post-op wards monitoring in medical wards when it comes to, intermittent versus continuous monitoring, because there's some real variation, I think, still.
So I think, Desiree, you're right. And I think the other challenge we have and why the challenge remains a challenge rather than something that we have fixed is because the context keeps shifting so much. So traditionally, obviously, we've not even had standardized models or methods of monitoring patients when they're in the ward areas. And it's not that long ago since we started systematic track and trigger systems. For example, in the United Kingdom, the National Early Warning Score, News 2, as we now call it, isn't that old in terms of how long ago we've implemented it. But despite that, we know that challenges remain in people's ability to be able to monitor things. So respiratory rate would be the classic example of something that we clinicians actually find really difficult to do correctly. So there's that, but there's also the element of what's happened in terms of acuity and staffing. So for me, who's been on the wards for longer than I can care to remember, if I think back, we used to have empty beds on wards. I can't remember the last time we've had anything less than 85, 90% occupancy. And I also can't remember when we had simple things to look after. So these challenges mean that our patient safety challenge will get bigger and bigger.
You mentioned something that I don't think we've talked much about, the news system, the early warning. Can you just tell me a little bit more about that?
It's just a track and trigger system because this patient safety challenge has clearly been identified for a long time. And one of the things we know that helps people improve quality and be on an improvement journey is having standardized methods of doing things. So the News 2 just essentially tracks parameters that you and I would be very familiar on that we can monitor at the bedside, things like heart rate, respiratory rate, temperature, blood pressure, pain scores. And we track and use those as trigger measures when certain thresholds are crossed. The challenge, obviously, to that is, A, we've said you've got to do it accurately, but also they're intermittent. So if your nursing rounds are every 6 hours, which is standard of care, there's quite a lot of time in between that you're then relying on other things being able to flag that patient's deterioration, staff going round, patient reporting symptoms. But we know that actually that's quite a long time and we often miss things.
Absolutely. And I don't know about how it is in other countries. I've heard a little bit, but in the US, typically when we are putting down respiratory rates and things like that are not hard recorded, as a blood pressure. It's basically, 16, 18, 20. So, does that happen?
So it's actually quite funny you should say that. So I was on a call earlier because the work that we're doing now is trying to really push into the surgical wards in terms of continuous patient monitoring. And my research manager was an ex-cardiothoracic specialist nurse. So the conversation was that the respiratory rates we know are 16, 18, 20, and maybe 22 and 23.
Oh my gosh. Tell us a little bit about the work that you have been doing in continuous monitoring and getting that into the floors and what you've seen, because that's kind of where we started our journey together a couple of years ago.
It is indeed. So in between, I've had a little bit of a detour in the sense that the United Kingdom's had a virtual ward program rollout. So I've done a lot of work in terms of bridging technologies into communities and helping provide specialist care for people at home. But I've just come back to restart my inpatient work. So at the moment, we're just about to launch the next phase of our work in the surgical wards, because I think the work that we've done to date, and we've written up and analysed and successfully had a PhD since we last spoke.
Wow, congrats.
Really, it's great. And it's really lovely to see my colleagues progressing with their research careers. But I think the work that we and others have done have really demonstrated very clearly the acceptability of this sort of technology to both patients and to staff, and that staff recognise that when it's done well, it has a real ability to lift quality of care. So Marco, I think, will talk a little bit more about some of the economic work that we've been involved in.
Yes.
What we're now really trying to do is hone down on two elements. So one is really proving that the outcomes that we all think are there and we've identified in retrospective analyses can really be borne out in real life. So we're doing some work on the surgical floor to really try and measure and start to track that. And then the other key element that we're looking at from a staffing perspective is the alarm burden and how staff can benefit from this technology and how they might interact with it in a way that actually improves workflow and staff experience rather than just becomes yet another system that we all think we have to do.
It's really my pleasure to introduce our next guest and bring them into the conversation. We have Dr. Marco Luchetti. He's an anesthesiologist and the medical director for patient care solutions for GE Healthcare for Europe, the Middle East, and Africa. Marco, thank you so much for joining us here on TopMedTalk.
Thank you, Desiree, for your kind introduction. Yes, actually, I've been practicing as an anesthesiologist and intensivist for nearly 25 years. And then recently, 7 years ago, I joined GE Healthcare as clinical manager first and then medical director. So I have a large experience in the field of anesthesia and intensive care to the point of deterioration. I think is one of the major patient deterioration is one of the major challenges today in a hospital setting. Everyone who has been involved in this knows very well that when you get a call from the ward, a patient is deteriorating and you go there, you never know what you can find, what the situation is, and it's always difficult to manage patient in that moment of crisis. So what we need to do is to prevent patients from suddenly deteriorating. Actually, they are not suddenly deteriorating. They are suddenly found to be deteriorated. Yeah. That's the crucial point.
My favorite quote recently has been, "It's gradual until it's sudden," which was a quote about bankruptcy, but I think that it is very, very appropriate for our patients.
Yeah.
Now, let me ask you a question, because I think as team anesthesia, as anesthesiologists and intensivists, we have a lot of information to give us a better picture of what our patients look like in the OR, in the critical care unit. I think it's hard for us to understand that the majority of our patients do not go to intensive care. They're going to the ward, where they go from very intense monitoring to not much at all. Is that something that I feel like that's a message we still have to get out there to our anesthesia colleagues?
Yeah, you are right. Of course, the vast majority of patients don't need to go to the ICU. It's a routine surgery. They have patients that don't have any underlying disease or comorbidities, so surgery goes uneventful and there's no reason to go to the ICU for the patient to go to the ICU. But there's a small percentage of patients that usually needs to go to the ICU. On one hand, because of the surgery. So the surgery is probably a major surgery. and there's the high risk complications. On the other hand, also patient conditions, so comorbidities or other complicating situation. But in the end, those patients need some sort of high-level monitoring. So it can be also that they need mechanical ventilation, but in most cases, they just need some monitoring.
Yeah. Sadia, why don't you talk to us a little bit more about some of the outcomes and things that you're looking at for surgical patients and the ones that really matter? Because, one of the things I want to explore here in just a little bit is talking about, is it continuous beat to beat of every single patient, or do we risk stratify? What are you finding are some of the problems that we need to make sure that we are getting enough information about?
I'm going to be honest, Desiree, some of what I say is about what I've learned during my own work, and some of it I think we've yet to determine and find out. And that's part of the real joy of working in this space, is just there's so much potential that technology can add for people. So for me, it's not about the technology, it's about the people, both in terms of process, but also in terms of those outcomes. Because unless we can really say we made a meaningful difference, I'm not sure why we should bother. We just shouldn't, should we? So for me, that issue of which patient, I think with my physicianly hat, I looked at it very differently when I first started this work. And I've been doing work in this monitoring space in an inpatient setting probably for almost close to a decade now. So quite a long time. And my very first look at this was to say, well, let's just put it on everyone. If we did almost everyone who walks in through the door, what's that going to look like? And what I realized very early was it probably wasn't a good way for us to go forward. Although I recognized the arguments about waiting areas in emergency departments. But the way modern healthcare works, a lot of people are seen and assessed in an emergency room setting or an acute floor setting and discharged really quickly. And if what we do is monitor all of those people, to be honest, in terms of the greatest yield from the technology, I'm not sure it's there. But if I look at it on the other side, if I look at those surgical floors and I look at those patients who are peri and post-operative, I think there's a huge potential gain, because those are the areas that we see a lot of transfers to intensive care. We see a lot of what we would call rapid response teams. I'm not sure what you would call them. Rapid response team activations. We see cardiac arrests from that floor disproportionately more than you might expect from the acuity and the demographics of the medical elements of those patients. I'm not ignoring how much of a challenge the surgery is, but if you just thought about that patient from a physicianly medical hat, the level of risk that they'd carry should in theory be less than the outcomes that we're seeing. And it's definitely that surgical period adds a whole load of other stresses.
In the US, we talk a lot about the utilization of technology and integration into practice and how to do that. Talk to me a little bit more about that, and really like this integration and making sure that it's right for, like you said, not necessarily just the patient, but the clinician as well.
So you were talking earlier about, the everything being gradual until it happens suddenly. And one of my favorite quotes is about, it's the technology looking for a problem. What we actually need is a problem, a group, all the stakeholders are invested in that problem to come together to say, well, what is the way that we want to work this? And I think one of the real challenges about integrating technology is, certainly if you think about how UK hospitals work, and I guess it's the same world over, is often the clinicians on the front line are the last people to know or to be involved in how a process around something works. So I think one of the real things that I've really loved doing throughout my work is the ability to work with frontline staff to decide how these things are going to go. And I think that has been a key measure of the success that we've had in terms of actually implementing and getting this work done.
Yeah. I've had lots of conversations in the space of medical devices and pharmaceuticals about how we use it and what's important to us as the clinician and what do we need, not what does the company think that we need to do this better. And I think that's, to your point, technology looking for a problem versus explaining what our problem is and what the solution is for it. So I think that's, so very important. In the next couple of days, I'm going to have another conversation with one of the authors of the Cosmos study, talking about alarm fatigue and how we can reduce that, because that is a true burden that I think is still, even though I feel like we talk about it a lot, it's still underappreciated about the burden of all of these alarms and all this information coming in. And with big data, you have a ton of information coming in to you as a clinician now. And it's like, how do I find out and hear the true signal versus all the noise? So I don't want to dive into that too much, but one of the things that we have to focus on when we are integrating new processes, but specifically new things that we have to spend money on to improve the process, is that, does this make a difference for our patients? Yes or no? If yes, how does that make sense? How do we show the value of that? And this is not necessarily just for continuous monitoring, but this is just in general. And that's something that you guys are kind of looking at, isn't it?
Yeah, it is. And just coming back to that alarm fatigue, yes, absolutely. It's a real problem. And unless it's sort of thought through in a way that is considered for both patient and for staff, actually it causes problems on both sides. So I think that's a real key area these technologies have to fix. And that issue of decision fatigue, the amount of data that we're exposed to is exponentially increasing on a minute-by-minute basis. And you and I already touched on the acuity and the volume that's coming through. But we forget that as human beings, our ability to process and actually make good judgments wears out very quickly. So that issue of alarms and how is data presented, we really have to be clear about when we implement not just this technology, but any other technology.
Yeah.
In terms of the outcomes and the impacts, we're really looking at those patient-facing things. What matters to patients? What about outcomes in terms of how long you spend in hospital? Is your illness, your infection or whatever it is picked up more quickly and treated more quickly for you? And we're also looking at that staffing element, because if I were a finance manager, and I know this because I've sat in enough finance meetings, 10 person trying to be that clinician, trying to get whatever I want to
exactly
at that particular moment in time, they'd be asking, well, where's the saving? And for healthcare, saving traditionally comes out of headcount, but we don't have enough nurses already. So we have to be really mindful of how we're planning to use technologies like this and how we ensure that actually we lift the quality of care, not try to substitute.
So when we talk about continuous monitoring for a ward patient, are we saying that this monitor stays on a patient 24/7, doesn't move, we never take it off, and that is where the value comes from? Or is it kind of intermittent continuous where it goes on for a couple hours at a time more frequently than just a blood pressure? Because that's a question that I've gotten recently and wondering about that.
So I'm going to be honest to say, I don't think we have the evidence base that tells us the clear difference between the two. I've always gone with the premise about, if you think about my cardiology background, my cardiac background, telemetry is something I'm very well used to. And remote device monitoring out in the community, I'm very well used to. So our model is 24 hours.
And that's where I think that, looking at the value of this and saying this is continuous, the value to the provider is that we get all this data, but we don't have all the noise from all the alarms. It's filtering all of that out for us. I think it's going to be very, very important. Well, as we wrap up here, Sadia, talk to me about the work that you and Marco have been doing around, and the team, around the value of utilizing continuous monitoring, because this is something that you both presented a poster, had an abstract recently, yeah?
It is indeed. So you've already touched on the work that JW had done in the United States, and obviously healthcare systems are the same yet different. So one of the questions that came up, particularly as we had done a lot of the work on continuous patient monitoring in a UK setting, is would those cost benefits that we're seeing in the United States systems translate across into the National Health Service? So I was really keen that actually we used our real world data. So we were looking at a whole year's worth of data of patients coming through what you would call, I think, med-surg, and we would call the general ward areas in Chelsea and Westminster, which is a 2-site institution of roughly 6,000 staff, 2 emergency departments, and all the traditional general medical, general surgical specialties, plus a bit added on that you might expect. So we had roughly about 20, if I remember correctly, 24,000 discharges from 2 hospital sites over a 12-month period. And what we basically did was took the elements of the model that they'd already published and reran that using our real world data. And we were actually able to evidence that we were likely to achieve significant cost savings driven by the things that we've already touched on: less rapid response team activations, less intensive care unit admissions, reduced length of stay. And
wow,
that was actually fairly eye-opening, because on the one hand, with my research hat, I'd been like, yeah, this stuff's great, we've got to do this. But when I'd been challenged to say, where are your hard outcomes and how does this come out to the money, I wouldn't have been able to evidence that before we did this piece of work. And when we did this piece of work, it's like, yes, it validates a lot of what we and others have been saying.
Yeah.
Marco, it looks like from the work that you guys did, you kind of took that model and put that into what you're doing over in the UK. So from your perspective, why don't you tell us a little bit about that?
Yeah, exactly. So we started from the study, the model study that the JW and colleagues performed with data coming from the United States, a community hospital in the United States. We wanted to, let's say, replicate this model study in Europe first. So we wanted to find data from as many countries as possible. But at the end of the day, we were able only to collect data, let's say, relevant data and meaningful data from the UK. So what we did is basically use real-world evidence from the Chelsea and Westminster Hospital, kindly provided by Sadia, and we applied the model that we took from the United States study. So basically, what we did is to use the reduction ratios. So how the implementation of continuous ward monitoring was reducing, to what extent was reducing some, let's say, variables. And so we applied those reduction ratios that was found, described in that paper, to the UK study. So basically, this was an easy way to model this for Europe. And let's say this is only UK, but at least for now. And the results were absolutely comparable to those in the United States, even better in terms of costs in the end.
All right. Well, we're definitely going to signpost people to the paper that JW did, and then hopefully for the abstract. Now, you guys are doing more work around this space and hoping to collect more data. Is that correct?
Yes, that's correct. That's totally correct. What we want to do now is collect more data from at least 3 or 4 major European countries and analyze those data using the same reduction ratios that we can extrapolate from the original study. Actually, those reduction ratios come from the original study from Brown. So this the original study where those reduction ratios were demonstrated for the first time. Then those were applied to the JW study and then transferred to the UK study. But then we want to have at least more data encompassing more European countries, because different realities, different experiences, different policies. So different countries may show different behaviors and different results in terms of main variables and in the end in terms of costs. So this is the reason why we want to study as many countries as possible.
Yeah,
and it's finding the good data, data, the relevant data, meaningful data, and complete data.
Yeah. So Marco, why don't you tell us what were the big headlines from the study that JW did? What was the actual cost savings?
Basically, what they found is that there were annual estimated cost savings for in-hospital stays around $3.4 million, 22 United States dollars. So for an adoption rate of 50%, and even of course even more, $6.8 million with an adoption rate of 100%. So this is really a huge savings in terms of dollars. And what's interesting to remark here is that the largest contribution to cost saving in that study was provided by the reduction in length of stay for patients that were not admitted to the ICU. So patients that avoided ICU admission because of early detection of deterioration. So this was accounting for approximately 50% of the savings. So this is an interesting result. So meaning that if we are able to prevent patients from going to the ICU because of deterioration, then we can save, of course, we can improve patient outcomes, but we can also save a lot of money.
Yeah, absolutely. Well, Marco, thank you.
Of course, just justifies the investment, the return on investment for the implementation of continuous monitoring.
It sounds promising. So hopefully we will be able to catch up with you guys in another year or so and hear some interesting results.
Thanks so much, guys.
Yeah, hopefully, yes.
Yeah. All right. Well, thank you for being so generous with your time here. I know, Sadia, you are sitting in your ward, it looks like now, or in the office. So I appreciate that. And Marco, I do appreciate all the time that you could give us today here on TopMedTalk, talking about this very important topic. Again, it's something that we have done series on. So if you want to learn more about specific types of continuous ward monitoring and things like that, you can go on TopMedTalk.com and find more information. Listen to our previous conversations we've had with Sadia about some of this work. And again, like I said, I hope we can catch up soon to hear more about it and what you are finding out now as you guys get into the surgical wards and find out more information. So thank you all very much.
Thanks, Desiree.
Yeah.
Thank you.
Thank you. Yes. Thank you for listening to TopMedTalk. You can find us out at TopMedTalk.com. We're in your favorite podcatcher. We're on social media. If you found this on YouTube, give us a thumbs up, subscribe. Every little bit helps. Thanks so much.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.